Hello, welcome to my channel Prime 32 Dental Lessons. Today's topic is curettage. Aim is to reduce pocket depth by enhancing shrinkage and new connective tissue attachment. It is done by scraping of gingival wall of periodontal pocket to remove the inflamed and soft tissue. 3 to 4 mm is normal. More than 5 mm pocket includes infiltration of bacteria. Types of curettage is gingival and subgingival. Gingival curettage is done by removal of inflamed soft tissue to the pocket wall. Subgingival procedure is performed by apically to junctional epithelium in connective tissue is severed down to osseous crest. Here you can see this is gingival curettage and this is subgingival curettage. So basically it is done to remove the unhealthy gingiva and allow regrow healthy gingiva. There is one more curettage, that is inadvertent curettage, that is accidentally done by while doing scaling and root planning. There are indications and contraindications. One is moderately deep infrapony pockets. Aggressively surgical technique are contraindicating owing with age problems like systemic and psychological. Maintenance of treatment is necessary for pocket problems. And contraindications are acute infections like acute necrotizing ulcerative gingivitis and deep pockets more than 5 mm, medically compromised patient who has fibrotic gingiva. Okay, so next is procedure of curettage. So basic technique is done by scaling and root planing. Deposits removed from the hard surface and smoothing to root surface is done. So then local infiltration and topical anesthesia is given according to for the convenience of patient. Then curate selection is done for the removal of supra and subgingival calculus. Gracie's curate is available in different numbers and universal curate is also available. So then comes gingival curettage. In gingival curettage, instrument is inserted so as to engage the inner lining of the pocket wall and is carried along the soft tissue in a horizontal stroke. Then pocket wall is supported from external surface with the help of finger with gentle pressure. Curate is then placed under the cut edge of junctional epithelium. So this is done, gingival curettage, and next is subgingival curettage. In this, the tissue is attached. The curate is placed between the tissues attached between the bottom of the pocket. Alveolar crest are removed with scooping motion of curate. Then area is flushed and debris is removed. And sometimes suturing of the separated papilla is done if needed with periodontal pack. Okay, next comes other techniques of curettage like ENAP, and that is excisional new attachment procedure. We'll talk about it in detail in next video. Next is chemical curettage, that is done by caustic drugs, sodium sulfide and sodium hypochlorite and phenol. These are not so beneficial and we have to discard it after some time or it gets ineffective. The extent of destruction is also cannot be controlled. That is a major drawback of these drugs, and these drugs can flow into the soft tissue areas and do much harm. And next is ultrasonic curettage. This is done by ultrasonic devices. Disruption of continuity and lift of epithelium results in narrow band of necrotic tissue and decrease in inflammation and less removal of connective tissue. These instruments are not as effective as hand instruments in removing connective tissue and leaving a smooth pocket wall. Next is clinical appearances after curettage. Immediately after curettage, gingiva appears hemorrhagic and bright red. And next, after 1 week, Gingiva appears reduced in height and slightly redder than normal. After 2 weeks, with proper oral hygiene by patient, normal color, consistency, surface texture, and contour of gingiva can be attained. So then gingival margin is also well adapted to teeth, and that's all. Thank you. Please like, share, and comment to tell what topic you want to see next. Don't forget to subscribe to Prime 32 Dental Lessons. Thank you.